This conference will now be recorded.
Hello, everyone. Welcome, and thank you for joining us for today's ACRM pandemic webinar, which is part of a series of webinars produced by ACRM and its community groups to help bring needed information to rehabilitation researchers and providers regarding the use of telehealth during the pandemic. My name's Tracey Wallace, and I'm the co-chair of the ACRM Pandemic Task Force, as well as the ACRM Technology Networking Group, which is the community group that came together with ACRM leadership and staff in the early days of the pandemic to initiate this webinar series. I'd like to personally invite those of you who are not already members to consider joining ACRM and the ACRM Technology Networking Group. Today's webinar was developed with collaboration from the ACRM Cancer Rehabilitation Networking Group. We appreciate the time and effort that Cancer Networking Group leadership has given to the support of this, and we especially thank them for recommending today's speaker. So today's webinar will be presented by Dr. Mackenzi Pergolotti, and it's entitled Revolutionizing Service Delivery to Meet Cancer Survivors' Needs in a Pandemic and Beyond. Before we get started with Dr. Pergolotti's presentation, I do want to advise that this meeting is being recorded. I'd like to ask all attendees to keep your phones or mics muted and to keep your cameras turned off throughout the presentation. We do expect to have about 20 minutes available for discussion at the end of the webinar. So if you have questions, just type them in the chat feature and we'll address as many of those as we can during that later part of the hour. And with that, it is my pleasure to introduce our guest speaker, Dr. Mackenzi Pergolotti. Dr. Mackenzi Pergolotti is the Director of Research for ReVital Cancer Rehabilitation and an adjunct professor at Colorado State University. As the Assistant Chief of the Occupational Therapy Department at Memorial Sloan Kettering Cancer Center, Dr. Pergolotti developed programs aimed to better address the needs of multiple populations with cancer. Realizing the impact of cancer rehabilitation provided at centers like Memorial Sloan Kettering Cancer Center, she was driven to build the evidence base and increase access to cancer rehabilitation programs nationwide through research. Dr. Pergolotti was trained at the University of North Carolina at Chapel Hill, where she received pre-doctoral and postdoctoral fellowships from the Cecil G. Sheps Center for Health Services Research, the Gilling School of Global Public Health in the Department of Health Policy and Management, the Cancer Research Outcomes Group, and the Geriatric Oncology Program at the Lena Berger Comprehensive Cancer Center. Dr. Pergolotti's predoctoral fellowship was supported by a T32 National Research Service Award institutional training grant from the Agency for Healthcare Research and Quality, and her postdoctoral fellowships were funded through an R25 Cancer Care Quality Training Program from the National Cancer Institute. Dr. Pergolotti has published over 40 peer-reviewed articles and has been featured in American Society Clinical Oncology Post's Women in Oncology. Dr. Pergolotti, we are very thankful to you for accepting our invitation to present, and we'll now turn the presentation over to you.
Great, thank you so much. I'm just trying to quickly figure out here. Okay, hold on 1 second. Okay, can you see my slides good now?
Looks good.
Okay, great. Thank you so much. Okay, and I just wanted to first start out with saying I feel very honored to be here today. I feel very honored to talk about this. I'm really excited about, and have always been excited about, the field of cancer rehab, but I feel like we are at a time where we have tremendous possibility. And I'm excited to be the one to chat about it with you, and I look forward to the questions at the end. I'd like to, hold on 1 second. Apologies. Okay. There seems to be a few slides slide deck is going at once. I apologize. So I'd like to just start out with just saying, I've been an occupational therapist for, about 20 years now. And like Tracey said, I started at Sloan Kettering Cancer Center. And there I was really able to see that and really experience how cancer rehabilitation, the power of it and how it can really work. And I was really driven to look at, as I moved to North Carolina and beyond that, I was really able to see that access to care and access to quality of care for cancer rehabilitation is really kind of limited. And driven to figure out what are the levers and what can we do to really change healthcare and healthcare access and how services are accessed. And so I'm glad to talk to you all about that today. Just as a quick disclosure, of course, I work for ReVital Cancer Rehabilitation Flex Medical. I am also on faculty at the University of North Carolina in Colorado State as adjunct. Okay. Excuse me 1 second. Oh, I'm sorry here. Seems to be a two-screen issue. So what I'll just jump in and start with here is a couple of weeks ago when I was asked to do this presentation, it was actually in the middle of a very personal experience that I'd like to share with you guys today because it really shaped the way I think about telerehab. On March 12th, I returned home from a work trip and quickly thereafter started to feel quite sick. I started to feel like I was coming down with something and kind of pushed on through the weekend. And then by Monday, I had actually become quite ill. I started to call my primary care office to see if I could see my doctor, and quickly after realized that there was very little, all of the doctor's offices were closed and I was unable to see any of the doctors. A few days later, I started to really have some trouble breathing. I was coughing and having a lot of trouble catching my breath. And that was when I had my first experience with telehealth. So throughout this, I had multiple experiences throughout this whole 6-week journey where I saw urgent care doctors, I saw my primary care doctor, saw even a pulmonologist, all through the comfort of my bedroom. And in some ways, it was really helpful in the sense that I was so sick, it was great to not have to leave my room or change out of my sweatpants. But it was also, kind of scary to be at home and not be able to have that personal experience with a clinician, that sits next to you and says, you're going to be okay, or that I can really hear my lungs. The only time I actually saw a physical doctor was when you see me here, the picture of when I was admitted, when I went to the emergency room to check on my vitals and my breathing when it became quite bad. When I had my own experience of COVID testing, which I had twice, which sort of felt like being in a sci-fi movie. Honestly, it was surreal. And then, of course, being at urgent care, where I was told to leave through a secret side door and not talk to anyone when I left. So I realized then how quickly and overnight how the healthcare system had really changed. And it was through that I started to really consider this was, my personal experience, and overall I'm quite a healthy person. And it was quite shocking to me and to my family to have this kind of experience. Even when I went to the emergency room, my husband had to literally just drop me off. I was having trouble breathing and had to walk in and go in by myself because visitors weren't allowed. So I thought a lot about my patients at that time and about patients with cancer. And I thought about how, if this is affecting me as a healthy person this dramatically, how is this whole pandemic affecting patients with cancer? And that was really at the same time when I was they came to me to see if I would do this presentation. And so we looked at, well, the first thing I wanted to start with is how does this impact the pandemic, impact the rehabilitation needs, and how are cancer survivors dealing with this, the impact of this pandemic now? And when we look, data is coming out more and more every day. I feel like we learn something new about COVID and the pandemic and how healthcare is changing daily. And what we found is that, patients with cancer patients with cancer are at a higher risk for being infected with COVID. And so they are restricting even more than patients without cancer, staying at home orders and social distance and physical distancing. And even those who are not yet infected with COVID are really being affected by the pandemic at large because of, like, if you think about my experience, how your interaction with healthcare has really shifted and really changed. There was a recent survey that was done by the American Cancer Society that found nearly a quarter of respondents have already experienced a delay in their treatment, and have been told that they don't even know when their treatment would be rescheduled. And so, or they have not been treated or seen for preventative measures. So things like mammograms and colonoscopies have been delayed. Furthermore, we also know that there's been many clinical trials put on hold. There was an article that came out a few days ago that said about 50 to 60% of research trials have either slowed down, had to change some of their guidelines, are not enrolling new patients, or not recruiting new patients. And so there's change in procedure. There's, patients aren't allowed to come in for research collection that's elective and not urgent. This is really going to change the way not only we see and think about healthcare for cancer survivors, but also the outcomes that we'll be looking at in the next year or two, or even longer, honestly. And one of the things that has been a bright light, I believe, in this change has been that oncologists and I would say even rehab clinicians, I'll talk about soon, are really moving towards this telehealth platforms and seeing new patients for telehealth. And patients, including myself, that had never had a telehealth visit before in their lives, have now been not only figuring it out, but figuring it out for the rest of my family, whoever else needs a telehealth appointment, and telling them how easy it is. And now, honestly, there's a lot of times when it's going to be what I prefer. And I think it's going to be similar to patients with cancer. It also made me think a lot about our perception of access. And when I've been thinking about access to cancer rehabilitation services for many, many years, our perception was always that there was an access as a common barrier for many with cancer rehabilitation. I mean, there's many studies, there's a handful of studies that show that, at baseline or before pre-COVID, patients with cancer, only 2 to 9% of them are receiving access to cancer rehabilitation services across the state. And those are of patients that really need our help. And really, when we thought about access to care, it was like, well, there's so many people that have a lack of access. Let's just try to get access to who we can. And then the patients that were really struggling, like those in rural communities or that couldn't leave their home beforehand, they were essentially told that at this point, we thought that Telerehab was a glimmer of hope, but but with the barriers of billing and other things, it was really a barrier that we were just really struggling with, and patients had to settle at the time. And now, as you can imagine, not just for rehabilitation, but everybody else, during this COVID pandemic, access to healthcare became an access issue for everyone, myself included, and even more for patients with cancer. And it made me really change my perception of access. Now, once access is a barrier for everyone, I think about, and that telerehabilitation has really taken off in a blink of an eye overnight, especially when you think of how healthcare changes typically. It really became, how can we use this as a way to really ignite change and maintain change throughout? it also, makes me think of, if you look at the bottom of the list, of the slide, as I was going through these slides, we were thinking of other disruptors, other things that have really moved fields forward, have really ignited different changes and things. And of course, I thought of Apple. If any of those who know me, I just love Apple products, for better or for worse. And it made me think of, like, this is not actually the Apple IIe, but one of the newer Apple products, many years, what was it, 2 decades ago, you would think about connecting to the internet, and it would be, connecting with the dial-up and that horrible sound we used to get, low memory, high cost, low accessibility, limited applications. And now if you think about the iPhone, when the iPhone came out, it not only disrupted technology as we think of it, but it really changed the way we think about computers and access to the internet, and access to information, period. And then when we translate that into what is this for oncology, there's 17 million survivors in the United States so far. And like I said, patients with cancer are already at a high risk for coronavirus infection due to being immunocompromised and other issues, being on steroids, et cetera. And we also know that patients with cancer who have coronavirus actually have a higher mortality rate than those that do not. What I started thinking about is that patients that are at home and they are physically distancing, or social and physical distancing from themselves, if we think that patients before COVID, or when healthcare was, 2 months ago healthcare, there were a number of patients that were having this cancer-related disability, this disability that was happening sort of quietly, and it was this cascade of events, and that patients would come and receive rehab once it was quite an issue. They had fallen and fractured a hip or broken a wrist or something like that, where now what's happening is that patients are having this decline, but they're not even going in to see their oncologist. So it almost makes that gap even bigger. And so as we were thinking, and as I was thinking about Apple, that, some of the quotes that I think have really helped me shape how I perceive this, and here's one of them. Some people see innovation as change, but we have never really seen it like that. I think it's making things better, and I couldn't believe this enough. I want to drive home that, this revolution that I think is really happening in healthcare can really be good, and I think is truly necessary for cancer rehabilitation at large, and I'm hoping to shine some light on that today. But first, I think, as we develop cancer rehab, it's always important to go back to the literature and the research to see what we've done and what we know so far, and to build upon that. So when we looked at what is the key research evidence that's out there when it comes to cancer rehabilitation in particular, and cancer telehealth, and each one of these studies sort of builds upon each other, but this is a study that honestly, it's one of my favorites. I recommend reading it. It's about patients' experience. What is their experience when it comes to interacting with telehealth and telerehab? And what patients said was that most of the time it allowed them, because they're in the comfort of their own home, to feel that they could be a little bit more vulnerable, and it helped to build trust between the therapist and the patient themselves. And there were a few things that really helped with that. I think it was the experience of seeing the patient's home, where they live, that sort of thing, but also the new interaction within the technology. And I'll bring up this study again later on when we'll make another point here. Oops. So I wonder why it's not. Okay. Sorry about that. The second study by Bray and others looked at web-based cognitive rehabilitation program. And so what I love about this study is that it's demonstrating that there is effectiveness when looking at web-based interactions and interventions for patients with cognitive impairment. Sometimes patients with cognitive impairment you think, well, with the technology, it might not be helpful. But in this study, they were able to show that even patients who at baseline had cognitive needs did better when they were able to interact with Telerehab. In this study here was actually done, there was a couple of studies that were done in Australia, and they were able to look at speech and language pathology for patients with head and neck cancer. And I found this paper also just totally fascinating. What they were able to show is that telerehabilitation offered in this way was at least equal to, and then sometimes even better for patients with head and neck cancer when they were getting speech and language pathology over the phone with therapists. And part of the reason this study worked really well is because they had sort of they explained it in like a hub and spoke model where they had the therapists in the local regions had access to a therapist that worked in the cancer center that had a lot of experience working with these patients. And so they could have this great ability to have this mentorship and access to information that really helped, I think, patients' experience, and also their outcomes were better. And of course, Kathy Lyons, all of her work, I think I've always been a huge fan of, but she brings such a unique perspective when it comes to telerehabilitation. When you think about working with someone, and this one was from an occupational therapy perspective, and using problem-based solving, a treatment program, and behavioral activation. So it was really talking to patients about, how can I help you in problem solving, how to either, build in physical activity in your day, or go through a functional problem or something that you're having difficulty with. And patients have there's been some really good outcomes on this study with patients with breast cancer. And she's done some really great work there. And that really builds the fact that there's evidence in OT, in speech, in cognitive rehabilitation, and of course also in physical therapy when it comes to telerehabilitation. The last thing I want to talk about, of course, is the Cheville study that was just published in 2019, and then the cost effectiveness study that was published in 2020 that we'll go into more detail in next. So if you look just broadly at the research, when you look at, well, who have we really studied to demonstrate that there's some feasibility and acceptability for patients with telerehabilitation? And so, like I said, there's been studies with women with breast cancer. There's been studies to show this feasibility and acceptability with patients with advanced stage cancer who have functional limitations at pain at baseline. Head and neck cancer, like I just mentioned. And of course, patients with cancer-related cognitive decline. In general, what do we know so far? Well, we know that cancer telerehabilitation has been shown to improve patients' functioning. It helps improve their coping and problem-solving skills, their quality of life, their cognitive ability, and actually it helps decrease the likelihood of being discharged, increases their likelihood of being discharged to their home if they happen to be admitted to the hospital during their cancer treatment. It's been shown to decrease the related pain, fatigue, anxiety, and depression. And I really think this speaks to the trust and sharing of vulnerability that can really occur through having that personal connection with someone while they're in their home. And even decrease the days spent in the hospital when patients were hospitalized. It results in high patient satisfaction with care, and like I mentioned before, can really improve the patient-therapist relationship and communication between patients and therapists. But what do we don't know? I mean, there's this preliminary evidence but we really don't have these best practice guidelines that are discipline-specific yet. And so we know that we need to follow the best evidence that we have and identify which key principles of that evidence would be good for best practices. So the COPE trial done by Cheville and colleagues was a trial, again, it was published in 2019, started in 2012, and then this is the cost effectiveness paper that was just published, I think, in February. And in this trial, they had 516 patients, individuals with advanced stage cancer. And these are patients that already had functional limitations and pain. What's interesting, it was a randomized clinical trial. They had 3 different arms. The first arm was what they called enhanced usual care. So there was some telephone monitoring, but it was mostly monitoring on how they're doing, like a monthly status report that would go directly to the oncologist. Arm 2 included a fitness care manager, which was a physical therapist that directly talked to the patients and really helped, like air traffic control, helping organize the information that the oncologist needed to know, and also with the local physical therapist. And so these patients were actually seen on Telerehab and also as needed in the clinic. And the third arm included everything in the second arm, but also included a pain care manager, which most of the times was done by a clinical nurse. When you look at the results of this trial, looks like my computer has frozen. Apologies. So the main trial that was published in JAMA Oncology, they were able to show that the physical therapist, that arm 2, when you had the fitness care manager that was doing the air traffic control, really patients demonstrated improved function. They had improved pain intensity and interference in their activities of daily living. And again, they showed that fewer days in hospital and enhanced likelihood of home discharge versus skilled nursing facility discharge. They were also able to show an increase in their cost effectiveness. So not only was the telerehabilitation with the physical therapist most effective out of 3 arms, it was also the most cost effective. So if you look at the incremental cost effectiveness ratio of $15,494 per quality of life adjusted year, and in this telerehabilitation, the cost effective strategy was a 95% of all the simulations. And again, the lower inpatient hospitalization costs. And I bring this up because this really fits in with value-based care initiatives that are already going on in oncology, that if we can offer patients access to care where they're at, then we can really decrease costs over time. Overall, they were able to show that telerehab was safe, feasible, and effective with patients with advanced cancer with functional needs and pain. I think this is a really important point that I want to bring home, because most of the time, a lot of the studies were done with patients with breast cancer or really early on or have it at early stage of cancer. And this was one where they demonstrated patients that needed the most, you could argue, do really well with this. One of the things that another thing the COPE trial did really well was they looked at a program that was already evidence-based, the REST program, which is an exercise program, and translated it for telerehab quite effectively. They used a patient-reported outcome measure as a screening tool, which I'm going to go into in a little bit more later on. And again, impact on cost. And they used this collaborative care model, that air traffic control model, where really helped, I think, pull in together the seamlessness of healthcare that it can be. So here's another, to quote Steve Jobs, be a yardstick of quality. Some people aren't used to an environment where excellence is expected. And I think in cancer rehabilitation, we can take the excellence that was done in the COPE trial and others and really pull it into our day-to-day care. So when we looked at, well, what are the best, what can we pull in to think about, like, the best practices for telerehab when it comes to cancer survivors? And there's 4 principles that I think we need to be thinking about. There's the administrative, of course, and that includes, the thinking about the billing and the administrative parts, that the infrastructure, those sorts of things. There's also the technological, the ethical, and the clinical. And when we're thinking, all of those have to be together to really fit and have really great build really best practices. Well, okay. So when I looked over the core standards and guidelines, just in telerehabilitation in particular, again, thanks to the adherence of both your institutional but also your state license laws and scope, you want to make sure that the technology is not only just fitting good fit and purpose, but is also of a high quality. We want to really think about client selection. Who are the best patients that can really benefit from cancer rehabilitation, telerehabilitation, and of course the client safety. So what are the things that we need to have in place in order to keep the patient safe? I think there needs to be more clinical education and professional development, so therapists know how to use not only just the infrastructure, but different ways that they can interact on a tele-rehab platform, how to pull up, even education on how to pull up the best exercises, that sort of thing, and work within evidence-based practice. And really the path to those best practices, I think, include both the principles for delivering telerehab services, thinking of that research evidence, thinking of how to use our best clinical decision making, really can come up with the best guidelines and best clinical practices. Again, to quote Steve Jobs, you can't connect the dots looking forward, you can only connect them looking backwards. You have to trust that the dots will somehow connect in your future, which I feel like we are totally in that moment right now. And there are challenges and, of course, opportunities to sustain this both now and throughout the COVID, the pandemic. So what are the challenges? Well, the first challenge, of course, and it was the first challenge, of course, on my mind, was really, what is the infrastructure? How are we going to do the day-to-day operations? And how do we do the day-to-day operations that are going to be sustainable so that after this pandemic, we can still offer telerehab to the patients that need it most? Like when I spoke about before, there's already a huge gap in access to cancer rehab, especially quality cancer rehab, with clinicians that are trained in cancer rehab and have an understanding of the specialty. This may be our opportunity to provide access to care for patients that may not otherwise have this. But we need to think about the operations and the day-to-day operations, of course, and our infrastructure, even down to like the platform that we're using. We need to think about how are we going to best implement the best practices, keeping in mind to share what our successes and challenges are. This is new for everybody. It's new for oncologists, and it's new for cancer rehabilitation therapists. It's new for rehab clinicians, period. How can we change? We need to be able to have this like open conversation about what works really well and where you're having challenges to really come together to build, I think, the best practices that we can as we're implementing an integration into healthcare and rehab at large. The patient expectations and awareness. When I mentioned that Cox study that looked at what are the patient's experiences when it comes to cancer rehabilitation, telerehabilitation, one of the things that they mentioned was a patient-reported outcome measure was really important, but it was only important when it was, and done well, when it was done consistently over time, so that the patients knew what to expect. So they knew what questions to expect, and they knew throughout their week that they were going to think about what those questions and how they're going to respond to that, because their therapist is going to ask them that question. And that's when it became really, really important. And I can't emphasize more that, especially in this pandemic, but even beyond that, the patient's perception of what's going on, what home is like, what their experience is like of having cancer in this scary time is so valuable and so important to how we're going to improve function and improve quality of life of the patients that we see. It makes me think about the times when, as a clinician myself, I was able to, sit on a bed next to somebody and just listen to them and hear what they were going through, and how impactful it can be that we have this ability to listen and be their champions and help them problem solve through what's going on. And I think patient-reported outcome measures can really help open that conversation. And lastly, I would say, policy and reimbursement. We have made some strides towards reimbursement for sure. However, there's, a lot of those really are on executive order and for this pandemic only. And I think it's really back on our shoulders to advocate for our patients that this is something that we should continue to build best practices for, but absolutely advocate for. Writing letters, speaking with your APTA and AOTA and ACRM leaders to say we need lobbyists to go talk to CMS and others to really get this paid for, because we have good evidence to say that it can be effective and really helpful. We already have these access gaps, and telerehabilitation can really meet a lot of the gaps that we already have in healthcare. You can focus on things that are barriers, or you can focus on scaling the wall and redefining the problem. This is our opportunity. It's our opportunity to take this pandemic as a way to ignite change, to be excited about change, and a way to really to build upon what we've already known and move forward much faster and be the iPhone and really change healthcare for the better. When I think a lot about, what are the ways that we can really ignite change, I think about how we look at health, the large public health version of cancer rehabilitation, how we look at health services research, and how we can use that as a way to change and build evidence towards a better model of healthcare. This figure here we developed it a year or so ago, and what it really demonstrates is that if we have better healthcare efficiency, where our personalized care is coordinated, rehab is given where it's indicated, and I would argue that high efficiency could also include patients that are unable to get to the clinic, that we're providing good quality telerehab care, can really lower the total episode of care costs that we saw in the Cheville trial and have ideal outcomes, better patient quality of life, function, and decrease, honestly, even potentially decrease clinician burnout. There is something to be said about that trust and build that can happen over the telerehab experience. When we looked at the agenda that we built, it's like how do we get to better access and better quality? I just want to call out the number 6, and we talked directly to really technology and how technology can make a huge difference. And I believe that in telerehab in particular, this could be how we move the delivery not only towards improving function, decreasing pain, decreasing healthcare service utilization, so decreasing that cost, but also helping community clinicians. Thinking about that speech and language pathology paper that was done in Australia, how can we lean on some of our experts in the field in order to empower those that are in more rural settings or not as close to a large cancer center or a cancer rehab clinic, that we can still treat patients with good quality of care, especially using technology. I think it can really revolutionize the way that we even look at our value metrics and how we report that. We can have, real-time assessments of outcomes and quality, because we're already using technology. It sort of enhances the use of a patient-reported outcome through technology, those sorts of things. But it'll require collaboration. It requires collaboration with the oncologists. It requires collaboration, with the technology companies. And honestly, it requires collaboration and alignment with our billing and policymakers so that they can see the importance of what we can do with cancer telerehabilitation to meet our patient needs. And lastly, I just want to leave you all with this quote. Life can be much broader once you discover one simple fact. Everything around you that you call life was made up by people that were no smarter than you, and you can change it. You yourself can influence it. And once you learn that, you'll never be the same again. I hope that this leaves you with an fuel for your fire as you advocate for our patients from now within this pandemic and, of course, beyond. And that's it. Thank you very much.
Thank you, Dr. Pergolotti. That was excellent. Really appreciate you sharing your expertise with us. I also appreciate how encouraging you are towards everyone to be an advocate, to keep what's got ignited, keep it going. I think that's outstanding. I also really appreciated hearing your personal experiences with telehealth. It was really great to hear, not hear that you had to have them, and I am happy to hear that you're feeling better now, but it was interesting to hear that the experience of being a patient receiving telehealth through a provider's eyes. And you did speak a little bit about how that kind of helped even grow the empathy for others in that position. I'm wondering if there's anything that might change your approach to telehealth in general, just based on your personal experience.
One of the things that really, that's a great question, thank you. One of the things that really stuck with me with the telehealth is that it didn't take much for my clinician to really reach out and make me feel heard and make me feel taken care of. So once I got it figured out with my primary care provider, we were able to make more connections, and I saw her more often than I think I would have before. And I really felt I had some real deep trust with her in that. And I think that's also something we can offer our patients.
Well, that's really interesting to hear too. I hadn't thought about that before, that perhaps because of the ease of access with telehealth, people might actually see a provider more and at the end of the day feel more connected rather than less. Because I know feeling connected, it is a concern some people have about introducing technology into how we deliver rehab. So that's really interesting to hear. So I do have a few other questions, but I want to encourage attendees listening to type any questions or even just feedback or thoughts that you have into the chat feature, and I will read them as they come, and we'll have Dr. Pergolotti address them. So while you all are thinking about whether you have something you might want to ask, I'll just move towards thinking, I'm imagining there are many of us out there that have never used telehealth before, and so you've probably convinced a great many that we should be considering it as an option. And so I'm wondering a couple things about that. For somebody getting started, is there anything that you could recommend somebody might think about when determining whether or not a particular patient is appropriate for receiving telehealth? Or are there certain considerations to be thinking about, or do we just, try to deliver it to anybody?
No, there's definitely, I think, some really good clinical considerations, things that I think you should think about. And I would say, thinking about cancer telerehabilitation is, first of all, as an adjunct to clinical care, and using your clinical decision-making skills to really decide, that's really where it lands on, I think, to decide whether or not this patient is safe to come in. One of the things, I think that there are things that you can do, by having either a companion there to help through the session, that can increase the amount of patients that you are able to see through a telerehab platform. And that's why I think that the COPE trial is so unique and so inspiring, is that, they had patients with functional needs and pain that were at home that they could really manage through telerehab, which I thought was really, really cool. So, and even patients with cognitive decline and those with head and neck cancer. Those are some populations that I would have thought initially, well, I don't know, maybe, maybe they wouldn't be as effective in telerehab, but we do have evidence to say that they are. So I think it boils down to a few things. I think it boils down to, of course, your clinical judgment, first and foremost, and whether or not you think the patient would be safe there. There's definitely some things, like, you know, for patients that are really high fall risk, there's some things that you can do in telerehab and some things I think that are better done in the clinic. But it doesn't necessarily mean that you have to make the decision of 100% telerehab or 100% in the clinic. You might want to blend the two.
That makes sense. And for people who are just getting started and even looking at platforms, is there anything that you would suggest people think about when they're, evaluating equipment or their setup and their need for the structure to be able to deliver telehealth services either effectively or safely? Any ideas of things that people should be considering?
Yeah, I think you definitely want to consider bandwidth. You want to make sure that you have a good, solid connection, especially if, when you're doing the video chat, and it really helps the ability to support those kind of connections. I think you want to look at a platform where you can potentially share other things. So if you could share a video at the same time of someone doing exercises, or even home exercise programs that you can share, that you can both be looking at them at the same time. You need to make sure, of course, that you have a platform that facilitates patient privacy and that follows, HIPAA compliance, those sorts of things, ideally. And you want to make sure that you're in a secure room. The last thing I would say is you want to also make sure that you're telling patients the platform that you're using and whether or not you have access to, taking photos of it, that sort of thing, so that they feel really safe and secure with you. And then the last thing is I would evaluate the ease of entry to the platform. It's really got to be one tough 2 clicks to get in and to open it up. And I think those few things would go a long way. It'd be really helpful.
Oh, that sounds like great advice. Thank you. I do see we have a couple of questions in the chat. And so I see one here from Dr. Timothy Marshall, who says, a year from now, where do you see telehealth and cancer rehabilitation? Will we regress back to where we were before the pandemic? Or will certain aspects of cancer rehab be delivered through telehealth, or that are being delivered via telehealth, continue to remain and evolve?
Dr. Marshall, thank you for your question. I think I am naturally an optimistic person. So I have, I'm truly optimistic that it will change the way healthcare is delivered. And I think that because of a few things. One, I think it's going to, similar to the iPhone, I think people are going to expect more. Our expectations of access are going to change. The expectations that I can stay in sweats, and still contact my healthcare provider when I don't feel well is not going to change once this pandemic is over. I'm still going to want to use that. And I don't think I'm alone in that. I really do think it's going to change that. I also think that, and I'm optimistic that it really, like I said in the beginning, I think this can really fill some of those gaps in care that we have, in places that we can't reach patients very easily, or they can't reach us. This is our way that we can really access them and get them the help that they need. But I really think in order for this to happen, we really need more advocacy, more letters to your congressmen and women and senators, et cetera, because we really, in order for this to be long-standing and long-term and sustainable, we need to make sure that payment is there, the infrastructure is there, and that payment is equitable to in-clinic payment. And I think that would be a key moving forward. So I'm optimistic and hopeful, but we need to make sure that we're standing up for advocacy.
Well, that all sounds like really important information, and it's funny you're ending that, but with another just reminder to be advocates. And here we have another question that starts off from Maria Swartz saying, thank you for being a tele-rehab champion. And then she goes on to say, what are your thoughts about the future of tele-rehab assessments? Do you have any thoughts on the mixture of objective and patient-reported outcome measures? It is my understanding there is a disconnect between patient-reported outcomes and objective measures.
Yes, that's a great point. I will say, well, I'll say this and then I'll tell you what my bias is, and maybe you'll be able to figure it out as I talk. There is a disconnect between, especially in the research I've read in oncology in particular, between objective measures and patient-reported measures. And what we've seen over time, before the pandemic, before telerehabilitation, is that clinicians at large, not all, but at large, miss a lot of the struggles that patients are having at home. Either they think that the acute late and lasting effects are not as severe or not as long lasting as the patients themselves are experiencing it. You know, the patient experience is their objective view of how they're experiencing the world. And I think it's just as equal to any objective measure that you or I would do in the clinic, in my personal opinion, of course. And I think that the use of patient-reported outcome measures, in particular, to get at that patient experience and what they perceive is going on at home, is even more valuable and more important on telerehab, because you're, you know, especially with the video platforms, you're in their home with them. So it's important to know how they are experiencing their home in order to really help them functionally improve their quality of life and decrease their pain. That being said, I think there's ways to do objective measures in a telerehabilitation platform. I think we could, you know, one of the objective measures I thought was really creative was hand grip, using a patient, like a scale. When you're measuring how much you weigh, you can use one of those scales to do hand grip. But that was kind of cool. There's ways that you can do, of course, the tiny dip and go safely, or you could do the 30-second sit to stand, those sorts of things, or thinking about patients' perceived exertion. Those kinds of things I think would be really helpful as objective measures that we can add to the patient's perspective.
It was really interesting to hear those examples, and really cool and creative too, to think about what people have already come up with to find more objective or ways to do objective measures via telehealth. Neat. Well, I don't see any other questions in our chat feature. So I think at this point, I'll just say to you, Dr. Pergolotti, thank you again for sharing your expertise. We really appreciate having you here. It was an honor, and I think this was an outstanding webinar. I also want to thank everyone listening. We appreciate you and invite you to attend again. We will have more, so please check out the ACRM page listing our webinars. I do want to advise that all of the recordings will be available, including this one, in the next 48 hours. And please do recommend this webinar to your colleagues. So this concludes our episode for today. Be safe and stay healthy, everyone. And we hope to have you join us again at the next webinar.
Thank you, everyone.